today is fluid responsiveness. Okay, fluid. We just discussed fluid, and fluid is like the most important thing. If somebody asks me what is the most important thing in intensive care, it is how to manage the fluids. In fact, how not to create problem. How not to create problem. That is the most important. How not to create a problem. That's the most important when it comes to fluids. It's not how to give, what to give. That will come. But the most important thing is when not to give and not to do things. That's most important. If you do not know when not to do things, that is when the problem comes in, right? So when you start thinking of fluid in the first place in the intensive care unit, when you start thinking of fluid in the first place,
patient with hypertension.
Sorry, patient is hypertension. No.
Trauma.
No. This is all ED. This is all what you're talking about is emergency room. This is all what is going in emergency rooms. You think of fluid when the patient is in. The patient, when they come to intensive care unit, they have passed the emergency room area, no?
Right.
You don't think of fluids for those reasons. So when will you think of fluid in the intensive care unit? When will you think of fluid in the intensive care unit? Hypotension again, for what? I mean, see, no, so the answer is not that. The answer is you will think of fluid in the intensive care unit when after initial hemodynamic stabilization, there are still features of organ perfusion deficit. That's the answer. Okay, that means see what happens in an emergency room is that a patient is already resuscitated, patient has already been given trauma support, patient has already been given fluids for a dehydration, then the patient comes into intensive care unit. Now let's take the example that the patient has been resuscitated over there. BP is supposed to come up, it's not come up. It's not come up, right? The BP has not come up after resuscitation. That is when you start thinking whether I need to give fluids. It is not rocket science to say that a patient is hypertensive, I'm going to give fluid at admission. At admission. That is not something that I'm even bothered. I don't even think. You understand? My thinking is not there only. The emergency room does not need thinking at that time. Now, if a patient comes with low BP, it is but obvious you'll start giving fluid. It's as simple as that, isn't it? Huh? That is the heart is okay, they will give fluid. That's as simple as that. Our statement is not there. Our treatment comes in after the patient comes to an intensive care unit, after the initial period of stabilization, if there is hypotension, it should have responded. This is one reason to think about fluid. So this is very essential. It's a core question to understand when to think about fluid. It's a very core question. Okay. One is this. Correct. What is the second reason? The second thing would be, you have an ABG at the start, okay, of your resuscitation. You came in and for some reason you repeated the lactates. Now, ideally what you should be doing, if by any chance you have given the fluid and the fluid has done good for this patient, the lactate should come down, no? Because the compensatory response should reduce, the lactate should start getting better. You may not improve it, but the lactates may start getting better. So in spite of your initial stabilization, if your lactates still remain on the higher side, okay, then I will start thinking whether I need the fluid. Again here I am not saying I need the fluid, whether I need the fluid. Okay, whether I need the fluid. It's not I need the fluid, whether I need the fluid. Okay, then the third step will be, you have basically had your initial hemodynamic resuscitation. The capital refill time is still prolonged. The capital refill time is still prolonged. And how do you do capital refill time? You press it for a period of around 5 seconds, you release and see what really occurs. If the capital refill fills within 3 seconds, at that stage it means that the patient is kind of okay. Okay, but however, if it doesn't fill up, means there is somewhere some problem. Maybe I may require to do. Who is here on this side? Is there a comment?
Sir,
I
am there, sir.
Okay. So capital refill time is the third thing, and the fourth thing is you have a patient who basically presents to the ICU in an altered mental status. So that is another reason which will you start thinking that maybe I need to understand whether the patient still requires fluids. So AMS, altered mental status. So these are the only 4 indications where you start thinking that okay, this patient requires some amount of fluid. Okay, so first thing very common is hypotension after the initial stabilization process. Okay, because here you're going to take a clear distinction of whether I'm going to give a vasopressor or whether I should be increasing the fluid balance. This is when the lactates are not doing well in spite of your initial stabilization procedures. Third is when the capital refill time is not really stabilized, and that's why, and the altered mental states. That's why if you get a patient from the ER into the ICU, These are the four things that you have to look for. These are the four things you have to look for when it comes to fluid management. Clear? So, if you think about what it is, you would start thinking, okay, then clinically, what do I do here? What do you do clinically here? What are you trying to assess clinically? Clinically, what are you trying to assess?
Patient is dry or...
No, ये सब तो हो गया. So क्या okay? You're saying you will assess some, but what are you trying to assess clinically with all these things that you're talking about, urine output and all? That is the things you're going to use to assess. But what are you trying to assess?
Hydration, enough hydration.
Volume.
Volume.
You are trying to assess volume status. Our entire idea is to assess the volume status. But that is a completely wrong thing to do. A completely wrong thing to do is to assess volume status. Because none of your clinical parameters will meaningfully tell you about a volume status. So, no clinical parameters, remember this, no clinical parameters tell you anything about volume status. No clinical parameters. Clear on this? Clear on this? So, what you are saying as clinical parameters, none of them will be actually volume status. Why? Why is that so? Any idea? Any idea? Because your body is a fantastic machine. It doesn't really respond, it doesn't really increase the volume or reduce the volume. What it does is it effectively changes pressures and perfusions. It effectively changes pressures and perfusions. That's what the body does. The body doesn't play, changes things. For example, if you have a patient who gets hypovolemic, okay, the body will increase the cardiac output, the body will increase the pulse rate, the body will increase the systemic vascular resistance, maintain the pressure, will not change the volume. So whatever you are looking at as end, just now you said urine output, what you are looking at CVP, all those things are not volume. They are the effect of a systemic vascular resistance, or they are effect of the tachycardia, or the effect of the cardiac output going up. You are getting the point? So it's not the volume. Volume, though, I cannot assess from in any way. Are you getting the point? I cannot assess the volume. They are only changes. So what happens is, the classical example is, you have a patient who's had 30 to 40% volume loss. Still the patient's BP will be normal. Still the patient will not be tachycardic. Still the entire body is warm. Still there is no problem in capillary fill time. Because that's how the body compensates. That's how the body compensates. So even a 30 to 40% loss of volume, even a 30 to 40% loss of volume does not alter your clinical parameters. It does not alter your clinical parameters. So let that be for a person who has got 30 to 40% volume loss of volume, actual volume, which we are trying to find out, volume. Even then, all your parameters, which includes blood pressure, which includes pulse rate, which includes cardiac output, which includes capillary fill time, all of these things can still compensate to get that volume under control, and you will not have a clinical feature at all. Are you getting the point? You will not have a clinical feature. Importantly, 70% of your volume lies in something called as unstressed volume in your body. It's venous capacitance. Your body has got two types of volume when it comes to 70% of your volume is lying in your venous system. 70% of your volume, okay, in your body, 70% of your volume is lying in the venous system. It's lying in the venous system. 70% of your volume is lying in the venous system. Okay. Now this venous system has got two kinds of systems. One system is called as stressed volume, and other is called as unstressed volume. It is a stressed volume that becomes venous return. It is a stressed volume that becomes venous return. It's a stressed volume that becomes venous return. And whenever there is a problem, each individual behaves separately by contributing from the unstressed volume into the stressed volume, and then stressed volume becomes venous return. You get the point? So whatever you are monitoring in your body with respect to all of these parameters we talked about is what volume? It is actually the stressed volume. Whatever you are monitoring. For example, you are monitoring the CVP. That is a stressed volume. But there is a huge amount of volume that is remaining back called an unstressed volume. So two people in this room, say let's take Kedar and let's take Avinash. They both will drop their volume, but both will respond differently with respect to stressed and unstressed volume. Both will have dropped 50% of volume. But you will respond differently. You will respond differently because it all depends on how much of the unstressed volume is gone into the stressed volume. And that's why measuring volume status is kind of impossible. It is impossible. So you can't look at the patient, feel the patient, touch the patient and tell that the patient is hypovolemic. You have to use a lot of other things to figure out what is to be done. The question is not, fundamental question itself is not hypovolemia. The fundamental question is, if I am going to give a fluid, is it going to benefit my patient? That's the question. You understand? You understand? And that is why you must know when to ask that question in the first place. To ask that question in the first place, I should be having all those 4 or 5 parameters. What are the 4 or 5 parameters again? You have hemodynamically given whatever fluid is required down, and now still the patient's hemodynamics have not improved, hypotensive. Patient's lactate has not gone up in spite of all what you have done. Capillary refill time has not changed. Altered mental status persists. And you can also say the urine output is going down. Okay. At that stage, you will want to think whether the patient requires the fluid. So my question is, if I give the fluid, will my preload increase? If my preload increases, will my contractility improve? Will my stroke volume improve? If my stroke volume improve, will it go to the tissue and will my perfusion improve? That is what we are trying to figure out. What are we trying to figure out? We are trying to figure out that in the event that all of those 4 parameters we talked about are there, if in the event that all those 4 parameters are there, if I give fluid, will the fluid cause an increase in the venous return? If it increases the venous return, does it increase the RV preload? Okay, if it increases the RV preload, does it increase the left ventricular stroke volume? If it does so, does it actually affect the tissue and gets into the tissue? And does the perfusion get better? So there is a lot of things in the way which has to happen if that fluid needs to improve the overall status. Are you getting the point? There's a lot of things that need to happen in this case for you to understand that the fluid has to actually improve perfusion. At the end of the day, we want the patient's perfusion to improve. And that is why CVP, if you say CVP is low or CVP is high, doesn't make any sense. So what? What is my aim? What is my aim? That's a question. If your CVP, you're trying to look at the CVP and say that my volume status is low or volume status is high, it doesn't make sense only. Because of the fact that a CVP will actually depend on the venous return. A CVP which is lying, this is the heart. Your CVP is lying somewhere here at the level of the pericardial reflection. The CVP is lying at the pericardial reflection. This is where your CVP is lying. Now, the amount of blood that is coming from outside is the venous return. Now, what we have understood that the venous return is actually the stress volume. Venous return is the amount of systemic vascular resistance. So we do not know the volume status at all. How much stress volume is coming? What is that? That is what we know, but we don't know the whole volume status. We don't know the whole volume status of this particular individual. You understand? So if you say the CVP is very, very low, it doesn't make any sense. There is no point because we are not still knowing the volume status. Are you getting the point? We are not knowing the volume status because volume is different. Volume is very different from what the CVP is giving you. Clear on this? Similarly, when we say that okay, I have seen the CVP and I have given the fluid and the CVP has gone up. Okay, that means the patient has responded to fluid. No, it doesn't still mean that. It just means that somehow the systemic vascular resistance has increased. It just means that there has been some increase in the venous return, but it still doesn't actually go and tell all of these things. It doesn't go and say all of these things. You getting the point? So then, do we use the CVP in any way? So if that is the case, why do we insert the CVP? The real indication for a CVP is to give noradrenaline, to give dopamine, to give whatever drugs if you want to give adrenaline. That is the real indication. In reports, that's the real indication. But then, do we use it for hemodynamic management or is it dead? Is there any way we can use the CVP? What do you feel? Any way you can use the CVP? Is there any way you can use the CVP? Any way you can use the CVP? Is there any way you can use the CVP? Anyone? You can answer. I mean, there is no problem.
When we measure cardiac output using transflumic modality.
But that is for using the cardiac. But otherwise, can you use the CVP for fluid responsiveness on its own? And when I say fluid responsiveness, what is the definition? The definition of fluid responsiveness: if I give a finite amount of fluid around 250 ml and the cardiac output increases by 10%, that is the definition for fluid responsiveness. It still doesn't guarantee your tissue perfusion here. It is only telling you that if I give X amount of fluid, that is 250 ml of fluid, my venous rhythm will go up, and because of that my RA pressure will go up and my stroke volume will increase. It doesn't tell you this end. You understand? It just tells you so much. It just tells you that अगर मैं fluid दूंगा तो ये मेरा इधर तक काम करेगा. It will work till my stroke volume. This is what it tells you. It doesn't tell you the end, that the perfusion will go up and the patient mental status will get better. It doesn't tell you all those things. Okay, it just tells you this. That is the only thing it will tell you. It doesn't tell you anything more than that. Correct? That is what your fluid responsiveness basically means. But what is our end game? Our end game is perfusion improvement. Our end game is that. And that is why, as clinicians working in the intensive care unit, you should understand all these concepts very well. It's very important to understand all these concepts very well. Okay, what you have now understood is that CVP per se as a number cannot be used. You can't say CVP is low, CVP is high, so I will not give fluid or give fluid. It doesn't work like that. It cannot be used that way. Can it be used in another way? Okay, if I have my CVP, I have my stroke volume. If I have my CVP, I have my stroke volume. And my stroke volume is increasing along with my CVP. Okay, mother, I need to say I gave fluid, my CVP went up, and my stroke volume went up. Okay, what does it say? That okay, maybe the stroke volume is going up after giving the fluid. Maybe it's suggesting that, provided you have stroke volume, provided you are monitoring stroke volume. Okay, so it's the same thing. I give fluid here. If my SV increases, it may be such that with this the patient is improving. There is fluid responsiveness. Maybe. You're getting the point. It's not. It suggests. You can't say yes or no. It's not binary. It suggests that if I give the fluid here, there is an improvement in stroke volume, provided you are monitoring it. Other way around, if I say that the CVP is gone up, but the stroke volume remains the same, this means mostly this patient is not responding. It suggests that it is not responding. So if I am monitoring my stroke volume, and I gave my fluid, and my CVP remains the same, CVP goes up, but my stroke volume remains the same at that moment, what is it indicating? It is suggesting that probably this patient was fluid non-responsive and you have harmed this patient mostly. So it's a positive fluid challenge. Are you getting the point? Are you getting the point? So by looking at CVP and by looking at stroke volume, I can maybe have these kind of associations. But for that, what do I need to monitor? CVP and stroke volume. I can't do it with any other thing, because if you look, this is the entire background behind it. If I have this, then maybe I can look something like this. Are you getting the point? Clear? How can I get this better? I can get this better if I'm looking at CVP along with flow parameters. This was all volume parameter. I can look at flow parameters. When I say flow parameters means kitna flow bahar nikal raha hai, which is basically done by VTI, also called as velocity time integral across the aortic valve. Okay, so if I give my volume and I keep my echo and my VTI increases, it just goes on to say that maybe my patient is fluid responsive, because now here we are not looking at volume, we are actually looking at the flow. Responsiveness, actually looking at flow. So you may be able to use CVP with flow parameters. It again suggests, it doesn't say for certain. It again does not say for certain. Clear on this? So here also this requires technical demanding procedure where you actually do the echo, you do the VTI, okay, or you have a pico in place which has stroke volume. Correct? So three parts of the entire story of CVP. As a number, doesn't make sense. If I'm going to use stroke volume along with CVP, it may give me an indication that patient may be fluid responsive, may give me an indication the patient is fluid responsive. And see, if there is CVP along with flow parameters, it might explain to me fluid responsiveness. So the three things we have discussed on CVP. Clear on this? So what have we understood to begin with? That clinical examination as a guide for volume doesn't make sense. As a guide for volume, clinical examination. But as a guide for what is happening as perfusion, it makes a lot of sense. So looking at it, CVP as a volume doesn't make sense. As volume, No. Clear? By looking at the number on the CVP, I can't say whether the patient is hypovolemic or hypervolemic. I can't say this. I can't say this at all. When we did do the concept of CVP and stroke volume, CVP and VTI, we are looking at the concept of responsiveness, not volume. We are not looking at volume, we are looking at responsiveness. Samajh mein aa raha hai? Are you understanding what I am saying? It is not volume. What we are talking about?
Responsiveness.
Clear? Two different concepts. Now the next thing so CVP is completely, and why it cannot be looked at volume? Because CVP, so if you say CVP, you can say JVP also. JVP also. Now what is the JVP after all? It is the venous return. It is the capacitance. It is the amount of SVR. It is of how your RV is working. It is a pericardial load. If there is a pressure from here, if the heart is not functioning properly, if the if the venous return is different from the stress volume, you can't find out the volume. You understand? Because the stress volume is different, unstress volume is different. So as volume, can you look at CVP or JVP? No. Am I clear on this? You cannot look at the CVP and say that the patient is hypovolemic, drill it in your mind. You cannot do that. It's not possible. Okay? Similarly, when you look at urine output, that was the next thing that came in your mind. When I actually asked you the question, the next thing that you told me was urine output. Now, what is urine output? Again, urine output is a function of renal perfusion. So, renal perfusion will change every time. For example, today, if I am having hypovolemia, what will my kidney system do? It will be intrarenal vasoconstriction. My tubular secretions will change. My kidney system will change based on what my body needs to do to maintain pressure. So will it give me volume status again? No. Are you getting the point? It cannot give me volume status because my urine output may be going low or high based on the pressure dynamics and not the volume.
Sir, if we give fluid to patient and patient's urine output was 20-30, then after giving fluid it comes to 100, 120, 200. So it means fluid responsive.
Doesn't mean fluid responsive. That is your perfusion improving for some other reason. It doesn't mean fluid responsive. Fluid responsive ka meaning hota hai, you give fluid, as I told you, fluid should cause an increase in the RV preload. The increase in the RV preload should simultaneously increase the stroke volume. If the stroke volume increases by more than 10%, the perfusion should improve. Fluid responsive ends when it comes to stroke volume. Ultimate goal is improvement in perfusion. So if you give fluid and the urine output improves, whether he was fluid responsive or that's a completely different dynamic. Perfusion has improved. Perfusion could have improved by many other things. It could have been your antibiotic. It could have been the patient getting less clinically, the antibiotic working much better, patient getting warmer, lot of other things. To say that fluid responsiveness has improved urine output, you need to first demonstrate improvement in fluid responsiveness. Otherwise, 50% of the times you are wrong. Because what happens is, if you want to give fluid and the kidney gets overloaded, not overloaded for that matter, back pressure, then what will happen? Perfusion will go down. So high CVP or no fluid, whatever fluid responsiveness is not there, then the urine output will not come. It will become even deteriorated. So 50% of the times this is what occurs. You give fluid, urine output does not improve, but you have harmed. You have harmed. How have you harmed him? Because of the fact that you have actually caused renal perfusion to deteriorate now here. That's why that whole cycle it is important you get the first one. So the first thing again I'm telling you, when you give fluid, there has to be an increase in preload. RA preload should increase, which should cause RV preload to increase. After RV preload increases, there has to be a stroke volume that increases. Once the stroke volume increases, there has to be an increase in the tissue perfusion, and this tissue perfusion should have the mitochondria to take up all these things so that the overall status kind of improves. So there's a lot of things that happens over here.
It's a part. It's not the whole story. Like giving fluid, patient output increases. That is a small part.
This is only telling you this.
Okay.
But when you do that, so for example, you give 1000 ml of fluid. Let's take the example. This part worked very well. You have got away. But 50% of the times, this 1000 ml will not be fluid responsive, and urine output will not improve. And when that occurs, you have harmed your patient. Because what has really occurred is, now even if he had to improve, patient will not improve because organ perfusion depends on CVP, depends on your venous return. So organ perfusion is equal to mean arterial pressure minus CVP of any organ in your body. Any organ in your body has got mean arterial pressure minus CVP or your venous return as your organ perfusion. You understand? So what has happened in effect, this 1000 ml has increased this part. It has increased this part. What has happened? Organ perfusion has come down. So if the kidney has to respond also, it stops responding. Okay, so what have we understood now? Urine output is another clinical parameter that does not talk about volume status, not responsiveness. Volume status. So we are till now not even reached responsiveness. We are still in volume status. We are till now discussing volume status. We are not talking about fluid responsiveness. We are just saying that our clinical parameter CVP or JVP, which is a clinical parameter, JVP you see like this, right? So JVP is equal to the CVP, cannot be seen and you cannot talk of volume. Clear on this? Similarly, you cannot look at the urine output and talk about the volume. The third thing you talk about is usually what? Capillary refill time. Whenever you're looking clinically, we also talk about capillary refill time. Even the capillary refill time cannot be looked and you cannot talk about volume. And can tell you why? Why? This is because what is your capillary refill? It is actually a perfusion at that distal area. It's a perfusion at your distal area. How is it changing? It depends on the sympathetics. Today, if your patient is very cold and is extremely sympathetically vasoconstricted, this will change. Capillary refill will change. Okay, that doesn't mean patient has got volume problem. It just means that the systemic vascular resistance has gone up. The sympathetics are working excessively. It just tells you that the body is still trying to compensate but losing compensation. It doesn't tell you anything more. You understand? So capillary refill time, what is it doing? It is just constricting so much it is doing. That's why capillary refill time is actually prolonged. So it is not giving me no information. It is just telling me that the body is fighting so much but it is not able to respond. The compensation that the body is using is so much. That means, as I told you, 30-40% गया, अभी body इतना compensate कर रहा है कि वो capillary refill time is getting prolonged. You're getting the point. But it doesn't tell me that the patient is volume loss चल रहा है. It doesn't tell me. So you can't look at the CRT and tell that the patient has got volume problems. Clear on this? Clear on this? So what we started by saying that none of the clinical parameters can actually tell you volume status. It cannot tell you. Now remember this, last thing you always talk about is IVC. Though it is not a clinical parameter, it is something you do bedside. Now bedside, if the IVC is just the central venous pressure, it has the same policies that comes with central venous pressure. The IVC is after all the CVP. The IVC goes from here, gets into the right atrium, and that is your CVP. So if the CVP is not working, in no way the IVC is going to work. So looking at an IVC and saying that it is small, he is hypovolemic is a wrong thing, completely wrong thing. Clear on this? Am I clear? And why it's important for you to understand? Today, I can make your IVC as thin as I want by just making you breathe heavily. Today, if I breathe heavily, my IVC will collapse. It is but obvious. If I breathe normally, my IVC will go big. Okay. So by looking at an IVC, I can't look at the IVC and say, "Arey, he is hypovolemic." You can't do that. Clear? Clear? And as I told you, that is really not the question only. The question is whether I need to give a fluid challenge, and if I have to give a fluid challenge, will it come to my objective of improving my 4-5 things? My lactate getting better, my patient getting better, clinically capillary refill time getting better. That is my objective. My objective is not to understand fluid or no fluid. My objective is to understand whether the responsiveness is there, and if that responsiveness causes the tissue perfusion to improve. That is where we are. Got this much to know? Got this much to know? You understood this? So it's wrong to be on the bedside and say he's hypovolemic. Because you can't do that. It's very difficult. When you do something and you find the improvement, you might say maybe he was hypovolemic. Clear? Because there are no clinical parameters, there is nothing in medicine that will tell you volume status. Nothing. Absolutely nothing. Because your body is a machine which actually compensates for hypovolemia. You understand? By changing pressures. Okay, so you can't do anything and say that this patient is hypovolemic. Right? So now this means I need to have a patient, some patients in which I will never do. So I have a number of tests that I want to do, right? So in order to judge, now I want to figure out whether I need to give the fluid to improve all those things, CRT, lactate, altered mental status, and hypotension despite fluid challenge. These are the things I'm looking at. So now my question comes is, I need to do something to understand whether if I give fluid, the responsiveness occurs. This is the first thing I have to understand. Only when the responsiveness occurs, I can look at the perfusion. First, that responsiveness has to come in. Then I can look at perfusion. Are you getting the point? So I need to answer two questions. One, whether if I give the fluid, there will be responsiveness. And two, I hope that the responsiveness actually improves the perfusion. So responsiveness and perfusion. Correct? So there will be certain cases in which there is no point of doing any of these. Which are those cases? These tests to understand responsiveness. So there will be certain cases. I'll give you an idea. You have profound vasoplegia. Patient is in severe septic shock. Severe septic shock. I mean, he is fully dilated. His vasodilatation इतना हो गया है कि diastolic is 20, 10. इसमें जाके तुम fluid responsiveness करके कोई मतलब नहीं है. वो vasoplegic patient है. उसमें जाके तुम all the tests that we're talking about, which we will talk about, उसमें करके कोई फायदा होता नहीं. Because he's profoundly vasoplegic. You are getting the point? वो patient में कोई मतलब नहीं है वो fluid responsiveness करने के लिए. Okay. The other thing is you have severe RV failure. If you have severe RV failure, what is our thing? RV preload has to go up, then the stroke volume has to go up, then perfusion has to improve. If your RV otherwise is not working, otherwise is not working, this will not go ahead only. तुमको stroke volume कोई मतलब ही नहीं उसका RV stroke volume बढ़ने नहीं वाला है. You are saying that the RV is not working. How will the stroke volume increase? Because we have a Frank-Starling curve. This is your curve, where here you have x-axis and y-axis. This is your output. This is your volume. If the heart is compliant, and working well, you give volume, your cardiac output increases. This was your cardiac output. It has increased. You give volume more, the cardiac output steeply increases. Okay. Then after a certain time, the volume you give, the cardiac output does not increase. That is the Frank-Starling curve. And all Frank-Starling curves are not the same. So if a patient is non-compliant, but the heart is not compliant, or systolic failure is there, this will be like this. So when it's like this, what is going to happen? I increase the volume, but the amount of cardiac output increasing is barely so much. Are you getting the point? So the Starling hypothesis or the Starling curve is a very important curve that tells us where the heart is. This is the thesis behind what I just now talked. Okay. So if the RV is not working, is there a point of doing this fluid responsiveness? No. And remember this, whenever you are on a ventilator, there is a very high chance that your RV is dysfunctional, especially when you have the patient on ARDS kind of ventilation, patient with ARDS. That's why you should understand how to figure out RV dysfunction. Because if RV dysfunction is there, all your tests for fluid dynamics doesn't make any sense. Are you getting the point? It's very interesting if you think about it. It's very, very interesting if you connect the dots together. You get the point? So you can't really figure out where if the patient's fluid response to RV is not okay. Okay. The other case, if there is mitochondrial failure, so at the end of the day, the fluid should go there, it should carry the oxygen, and that oxygen should be then taken into the tissue. That is what we are trying to do. Giving the fluid, oxygen is reaching that area, and then the perfusion is improving. If there is intense mitochondrial failure, severe septic shock, patient, some toxicity, some poisoning that is there, which is causing mitochondrial failure. In that case, if you try to do all of these fluid responsiveness, it doesn't make sense because tissue perfusion is not going to improve in any way. Are you getting the point? Tissue perfusion is not going to improve because it's mitochondrial failure. You understand? So there are certain cases in which all these tests should not be done. And I just enumerated a few tests, few cases. So which will be that case in which I will do? Just now what I told you. Patient has come, patient is still come to your place, and patient is not kind of improving. That is the case where I will use my fluid responsiveness indicators. You understood this much? Till now everything is clear? Which case I am going to, yeah. Now that you know when to ask the question. The first question was, you have to be very clear, the volume you cannot judge. The second question is when to ask the question whether I should give fluid. Now you know when to ask that question. Okay, so two questions I said, or two things I have now, I have got very right over here. One is volume cannot be measured. Intravolume status cannot be measured. There is no way you can judge intravascular volume status in intensive care unit. Number one. Okay. Number two is that you should know which patient to ask the question. Which patient, which kind of patient I should be able to ask the question that whether this patient requires the fluid. Now you got that also, those 4-5 parameters I told you. ये 4-5 पैरामीटर में हम वैसा सोचेंगे, ठीक है? Now also you will obviously as time goes you will realize कि I need to have more patients of this nature where I have to ask this question. Okay, asking the question. So ask the question. The third question is, how do I know fluid responsiveness? That's the final most important question. How do I know fluid responsiveness? How do I know that the patient is fluid responsive? Now,
passive leg raise.
so let's go one by one. So do you know the tests that we have for fluid responsiveness?
LVOT VTI, we'll just check after giving fluid boluses.
So you are saying fluid bolus. How much fluid bolus?
200 to 250 ml initial bolus.
200 to बहुत ज़्यादा हो गया. 200 250 तो मेरा fluid challenge ही हो गया मेरे लिए.
Initial bolus will give this much, and we'll see for responsiveness by LVOT VTI or passive leg raise test indirect measurement.
You want to do PLR, and then how much? How?
PLR is like keeping patient supine
and what you want
45-degree leg.
Keeping patient supine and take 45 degrees up.
Leg
up. And then?
So then it will be like bolus of 300 ml of fluid. Then
we'll
we'll check for LVOT VTI.
We'll check for LVOT VTI.
Then that measurement should be 18 to 20 centimeter.
Anything else? PPV.
SPV, PPV, SPV.
PPV you talked about.
More than 13% improvement after giving fluid challenge.
13% improvement after giving fluid challenge. Okay.
Stroke or imitation.
Anyone? Anything else? Anyone? Anything else here?
Even like patient is on ventilator, again increasing the tidal volume, seeing the pulse pressure variation.
How do you do that? You see the pulse pressure variations. How do you do this?
We increase the tidal volume and see the pulse pressure
How quickly?
variation in 2 minutes.
So that's the reason that we are having this discussion. None of these answers are right. All of them are completely wrong. Completely wrong. I mean, unless you know the right method to do whatever we are doing, unless you understand the physiology behind it, you can't decide on a method. These, whatever we have method are very vague. Whatever we have said is very, very vague. Now you understood how important it is to judge fluid responsiveness. If you do not judge fluid responsiveness better, well, you are harming the patient, correct? That you understood. And that's the reason that you all should understand what is to be done and how do we do each of those tests. So what we are going to do is, we are first going to make an algorithm to understand which test where. So we just told many tests. Which are the tests we said just now? We did talk about a few words and we'll come to those words. So he did talk about something called PLR, passive leg raise. Then he talked about PPV. Then she talked about TVC, pulse pressure variation, tidal volume challenge. These are the three things. Any other thing you want to answer? Anything else? That do bedside usually very often. Very often you do bedside. The machine you do it.
IVC.
Okay, so there are so many things that you are looking at, but then you should know where, when, what, why. Okay. Now, what is the meaning of PPV? Let's understand one by one. What is the meaning of PPV? What is meaning of PPV? What do you understand by PPV? You have done anesthesia. What is the meaning of PPV? Any idea? Anyone? Anyone? You can make these mistakes, no problem. What do you understand by PPV?
So there is so before giving the fluid, we see the pulse pressure, and then later on we can see if there is
After
any
fluid
improvement.
challenge, we'll check for like, if it is improves 13%.
No. So very wrong concept, very wrong. Okay. So what is PPV? Pulse pressure variation is actually an interaction of the heart and the ventilation. The interaction between the heart and the ventilator is called as pulse. When that gets interacting in such a way that it causes like a fluid challenge, like an internal fluid challenge, and it changes the entire dynamics, it's called as PPV. For example, if the patient has got positive pressure ventilation, okay, or he's breathing, there's an inspiration, the venous return increases. Okay, when the venous return increases, your amount of bolus is going inside your heart. From the RA, it is going to RV. Then if the RV contracts properly, in a couple of weeks later, that same RV gets into the left side. From the lungs, it goes and comes to the left side. Then the left side improves. So in a couple of beats, first beat में क्या होगा? Blood pressure बढ़ रहा है. Second beat में क्या होगा? Blood pressure कम हो रहा है. Pulse pressure is systolic pressure minus diastolic pressure. That is pulse pressure. This is pulse pressure variation. This means to say, when the patient is actually getting inspiration, when getting inspiration, what is happening? There is a large amount of fluid. I mean, this is let me put it diagrammatically for you. Okay. So you have the heart. You have the venous return. Okay. This goes into the lungs. Okay, they go to the lungs, and from the lungs, this goes back into the left heart. Correct? Correct? Correct on this? Let me just draw the lung like an alveolus, so this makes it easier for you. You are able to see this on the. So, let me draw it as an alveoli for you. Okay. So again, I'm repeating: venous return, RA, RV, from here pulmonary into this circulation. Then the alveoli is here, capillaries, and then from here it goes into pulmonary veins, left heart, and from here it becomes a stroke volume. Clear? Now, what are we looking at? We are looking at a situation where suddenly there is inspiration. When there is inspiration, what is going to happen? This is going to squeeze this area. It's going to squeeze this completely. It's going to squeeze this. Clear of this? When it squeezes, what is going to happen? Blood is going to rush from here. Blood is going to rush. Okay, because it's squeezing, na? So when it's squeezing, blood is going to rush from here. That means here the cardiac output first is increasing. Correct? Cardiac output is increasing. This is what is occurring. Now when a larger amount is moving this way, this septum is moving this way. The septum between the right and the left is moving. This is called ventricular interdependence. This is called as ventricular interdependence. Each ventricle is dependent on the other ventricle. Okay. So what is going to happen? The blood is moved over here, septum is bowed outwards. Okay. At the same time, this high pressure has caused this back pressure from this side. So what is happening? The venous return is reducing because pressure is going to increase here. If the pressure is increasing from here, venous return is passive. This is reducing. Correct? The pressure is increasing. Now this is moving this way. This is pressing from here. Afterload is increasing. So what is going to happen? The venous return is decreased. Since venous return is decreased, first output that's coming out, cardiac output is first increased. First cardiac output is increased. Clear on this? And after that, this venous return is coming, this will come over here. Then after a couple of beats, this will come here. After a couple of beats. And after a couple of beats, when this blood comes here, there is lesser. Correct? When this is lesser, the next cardiac output is dropped. Correct? And pulse pressure is one of the common ways to figure out an estimation of your cardiac output. Okay, so that means to say pulse pressure is mirroring your cardiac output. your pulse pressure. It is closest to your cardiac output. It is close. It is not the cardiac output. It is closest to your cardiac output. So what will happen? Initially, I will have along with the respiration. You're understanding? I will have my systolic pressure minus diastolic pressure to vary. It's going bigger. You understand? So it has become bigger. My pulse pressure has got bigger, which is equal to my cardiac output, and after some time it has become smaller. This is exactly what this pulse pressure variation is all about. This is what all this pulse pressure variation is all about. This variation, if it is usually, if the patient is actually fluid responsive, this variation is very big. You understand? So if this variation is more than 13%, if this variation, I don't need to give a fluid for this. If my variation is more than 13%, it just indicates that maybe it suggests that my patient may be fluid responsive. Clear on this? Now comes the catch. The catch, there are two major catches. The big catch is the fact that one, for this interaction to take place, the heart and the lung has to interact. Correct? Correct?
Yes.
For this interaction to take place, that there is dynamic changes. There is dynamic changes. Till now, when we say CVP, urine output is static. To see this dynamic change that is going to occur for this particular purpose, the heart should interact with the lungs. The heart should interact very beautifully with the lungs. Clear on this? If it does not interact with the lungs, this variation is not seen. Because unless you increase the pressure in the lung, the changes will not be seen. So, in spite of the fact that the patient is fluid responsive, if you actually gave low tidal volumes, it is not going to work. समझ में आ रहा है? If you give low tidal volumes, it is not going to work. And what do we do in our ICU? We actually give low tidal volumes. You understand? So if you have low tidal volumes, it will not work. So the approximate amount of tidal volume you need to give is 10 ml a kilogram. 10 ml a kilogram, 8 to 10 ml a kilogram, for something like that. 8 to 10 ml a kilogram, which we normally don't give our patients. Clear? So that is the first thing that should be there. So before even you interpret that PPV that you're seeing over there, आपके मन में क्या क्या आना चाहिए? I'm explaining to you that all. The first thing is my tidal volume adequate to cause that variation? So it's possible that actually variation is there, but my tidal volume is so low that it is not doing that. The second thing, the compliance of the lung has to be good. लंग का प्रेशर ट्रांसमिट होना चाहिए. लंग का प्रेशर अगर ट्रांसमिट ही नहीं हो रहा है, लंग का प्रेशर ट्रांसमिट ही नहीं हो रहा है, तो फिर क्या फायदा होगा? जैसे कि अभी मेरे पास ये दीवार है, मैं दीवार को कितना भी प्रेशर मारूं यहाँ से, वहां प्रेशर नहीं आने वाला है. वहां प्रेशर नहीं आने वाला है. अगर मैं दीवार फ्लेक्सिबल होता, मैं यहाँ से मारा तो पीछे प्रेशर आ जाएगा. So if the lung compliance is like stone, like ARDS lungs, so this pressure will not go there. So if the patient has low lung compliance, this is not going to work. So clear on this? It is not going to work. Correct? First, second, third. If this patient has got a rhythm disturbance, again this is not going to work. If this atrial fibrillation, cardiac output बराबर आ ही नहीं रहा, आपको क्या देखना है इनमें? Cardiac output, ये तो इधर उधर हो रहा है. समझ में आ रहा है? जब इधर उधर हो रहा है, तो मैं कहाँ पर cardiac output पे concentrate करूँ? मैं कैसे pulse pressure देखूँ? समझ में आ रहा है? So third thing, if the arrhythmia is there, it doesn't make any sense. Fourth thing, anything you know, if the patient is breathing on his own, अगर patient खुद श्वास ले रहा है, तो venous rhythm उसके श्वास की वजह से हो रहा है. It's not that the patient's volume status is low. जैसे मैं तुमको बोला, I can reduce my IVC if I give too much of pressure. ऐसे करूँगा my IVC will collapse. I will distend. Sorry, you understand? I can do that myself. Heavy breathing will change everything. So if the patient is breathing on his own or triggering the ventilator, if the patient is triggering the ventilator, which all our patients do, okay, this PPV will not work. So if the patient is assisted ventilation or the patient is spontaneously breathing, PPV will not work. Simple. So remember this. in intensive care unit now, you may have the best of the best equipment. But if you do not know when, why and how to use it, it is completely useless. It is completely useless. And that is the reason we are having these talks, so that you understand how to use those machines, how to use them for your benefit. Clear on this? So pulse pressure variation kabhi dekhoge when this is all there, when the tidal volume is on the higher side, when the patient's compliance of the lung is okay, when the patient does not have arrhythmia and the patient is not breathing on his own. So spontaneously breathing individuals mein hoga hi nahi. Clear on this? Huh? Clear on this? Unfortunately, 90% of our patients will not fit this. And those patients who don't fit this don't require a fluid challenge only. They are so stable. Are you getting the point? Huh? 90% of patients will not fit this criteria. And those patients who actually require it, they will not require only a fluid challenge usually. It's like that. They are so stable. Are you getting the point? Understood? PPV समझ में आया? All of these things has to be in place. Then only we can use the PPV, which is easily available on our monitors. Clear? Clear on the PPV? So then what do I use? So let's divide them into two parts. The crux question would be, am I having a patient on spontaneous ventilation with patient triggering on his own versus the patient was passively ventilated? These are the two things I must take. Okay, and when I am spontaneously breathing or ventilated with passive mode and active mode. Matlab he is assisting himself. He is assisting the ventilator. Ventilator is assisting. So either ventilator is assisting or ventilator is not assisting. That is completely passive patient. On the other category is patient who is spontaneously breathing. Every patient is not on the ventilator. Correct? So we need to understand where, what, why, when, how. So in spontaneous breathing patient, what do I do? So many of your patients would be this category. Spontaneous. Where the patient is breathing on his own, is not on the mechanical ventilator, or you're in that same question, asking that question that whether I should give the fluid or not. Many of your patients are like that. So the one test that is supposed to be used in such cases, and very important test, is actually PLR, passive leg raising test. Okay. Now importantly, the passive leg raising does not need ventilation. It does not need the patient to be in normal sinus rhythm. Patient can be breathing on his own. Okay, and patient has no other reason to have any problem. You understand? We can do passive leg raise in every patient excepting three categories. Okay, first category is those patients who have raised ICP. If you have raised ICP, you can't do PLRs. It will cause raised ICP. Correct? Second, you can't give it when there is intra-abdominal hypertension. You have an expiratory laparotomy, you've got IH, intra-abdominal hypertension. You can't use it because that pressure will transmit to the IVC. And third thing, you can't do it in a spine patient, right? You have a spine patient is kept in supine, you can't keep doing passive leg raise, it is dangerous. Right? Unless a surgeon clears you. Mostly they not clear after surgery. Okay? Immediately they not clear. Clear on this? PLR testing? Understood which patient, you understood which category of patients you will use and which category of patients you will not use. Category of patients you will use all excepting these. All excepting these. Clear? Clear? Now how do I do the PLR? Now PLR, how to do it is very, very essential. How to do the PLR? Okay, what are the prerequisites to do a PLR? The prerequisites to do the PLR is the patient should be not having any change of vasopressors immediately. पहली बात तो ऐसा नहीं हो सकता कि तुम 2 मिनट पहले उसका vasopressin change किया, noradrenaline change किया, now you want to do PLR. You can't do that. It doesn't make sense because you're changing the dynamics. You understand? So abhi say 10 o'clock I did my change of noradrenaline and 10:05 I'm trying to do my PLR. It doesn't make sense. You understand? There should not be immediate changes of vasopressors before you do the PLR. Number one. Number two, patient should not be extremely anxious. If he's a spontaneously breathing individual, should not be extremely anxious. He should be relaxed. So you can't have him to be anxious because if he's anxious, what will happen? He'll do all that. He will press upon the IVC and everything that you want is going to change. He cannot be anxious. If he's anxious, your PLR doesn't make any sense. Okay. Third thing is you need a real-time monitoring of cardiac output. So 3 things. What are the 3 things? Patient factor, machine factor. What equipment you require? Okay. Patient में what? Patient should be calm. Okay, calm. Patient cannot be aggressive, cannot be thrashing about in bed. He can't be sympathetically overactive. It's not possible because it will cause problems. Machine factor, you require monitoring of cardiac output or stroke volume in any way. Okay. Now, cardiac output stroke volume can be monitored in 2 ways in the ICU. There are many ways, but what we use is either a PICO to monitor cardiac output or LVOT VTI. That is the echo. Okay, LVOT VTI, left ventricular outflow tract velocity time integral. Okay, which is not easy to do. It is really not easy to do this because you have to keep your hand there. You have to give PLR and check, which is very difficult. Okay, so what we are left with is monitoring. So you cannot do this monitoring mean arterial pressure. You cannot do this monitoring urine output. You can't do this monitoring pulse rate. You can't do this monitoring any other parameter. You have to have cardiac output stroke volume. You cannot do it in any other way. It is not possible to do this in any other way. You should have this in this if you want to do the test properly. The question is, how do we do the test? Okay, to do this test, as I told you, the first thing that we're going to have is the patient is calm and quiet. So these patients need to be at a position that looks like this to begin with. Okay, you cannot be in supine position. It has to be a semi-recumbent position. It has to be a semi-recumbent position. Very, very essential that is semi-recumbent position. Okay, now what is the principle of the PLR and why is it so interesting? It is so interesting because you are giving a fluid challenge and reversing it. You are giving a fluid challenge and you are reversing it. Basically, you are testing the system for an improvement in stroke volume and then calling it as fluid response. So that's your exact definition. Your definition is, if my fluid causes an improvement in 10% of stroke volume or cardiac output, my patient is deemed or suggested to be fluid responsive. This is exactly what you're doing when you're doing a passive leg raise. This is exactly what you're doing a passive leg raise. So let's take the feature that you have a PICO monitor. So your PICO monitor should show cardiac output. It should show stroke volume. It should show either cardiac output or it should show stroke volume. Real-time estimation of stroke volume should be there. Or real-time estimation of cardiac output should be there. Clear? Now let's take that you have a monitor and the monitor shows your cardiac output to be 2.6. It is 2.6. Your BP was low. I am not concerned with BP here. As I told you, BP is pressure. We are concerned with whether my fluid is going to improve my cardiac output. So my entire thinking is, what is my cardiac output when I am doing my PLR? Correct? So what do I do in this case? I want to ensure that a combination of my leg and my splanchnic circulation gets into the heart. Leg and splanchnic circulation gets into the heart. So 150 ml into the heart. Clear? So 150 ml from both the legs, 150 ml from the splanchnic circulation, total of 300 ml getting into the heart. This is what I am trying to do by PLR testing. So my patient will remain in this position with the leg to be supine like this and semi-recumbent. Okay, that is my first thing that I will do. Okay, ideally what is supposed to be done? Ideally, without upsetting anything on this patient, the patient should be converted to a position like this. Ideally, that means the bed should simultaneously move down and raise the leg. Simultaneously. Okay, that is the original PLR. The original PLR is simultaneously, if the patient is like this, simultaneously becomes like this. But we don't have such beds. Many people don't have such beds. They are very high profile beds to do that. The PLR beds are very, very high profile beds. There are specific beds that do PLR testing. Okay, where if the patient is like this, you press a button for PLR, it becomes like that, 45 degrees. You understand? So the leg has to be 45 degrees up. Unfortunately, we do not have such beds. 99% hospitals across the world may not have PLR beds. It's very expensive beds. Clear? So what do? We do a two-step PLR. Now what is a two-step PLR? The two-step PLR is, I will first move the head down. What will I do? I will first move the head down. So So I'll keep semi-recumbent. Move the head down. Wait for 15 seconds. I'll wait for 15 to 20 seconds because now I need his body to adjust. I need his body to adjust. You understand? So initially, obviously there will be changes in the vagus, a lot of changes are going to occur. So when that is occurring, wait 15 seconds. You wait. After you wait for 15 seconds, next step will be raise the leg to 45 degrees. This can be done by either placing a pillow under the bed, a pillow, blankets, or just raising the leg. It is not good to use a pillow or a blanket. You have the facility in most of your beds where you can raise the leg, but you have to raise the leg to 45 degrees. The leg cannot be like this. The leg cannot be like this. It has to be up. You know, it cannot be like this. It cannot be like this. The leg has to be up 45 degrees because I want to ensure that 150 ml goes into the body and my splanchnic circulation is also going into my body. And now you understand that if I have intra-abdominal hypertension, I can't do this. Because the pressures over here will not really translocate those fluids. You can understand that I cannot do it if there's spine trauma. I can't do it. I can't do it when there's ICP because I'm doing the right opposite of what I'm supposed to be doing, isn't it? Clear on this? And now how do you do this? How do you time this? You time it this way, that you first keep the patient in the supine, see the cardiac output. First take it down, 15 seconds हो गया, उसके बाद take the leg up. That is the time that you start monitoring. That is the time you start monitoring. The time you take the leg up, immediately at that time, you start monitoring the cardiac output. You start monitoring the cardiac output. 2.6, we started at say 2.6. Keep monitoring at this. For how much time? You monitor it for a total of 60 seconds to 90 seconds. You monitor for 60 seconds to 90 seconds. You can't keep monitoring it. 60 to 90 seconds is what you're going to monitor. In 60 to 90 seconds, if you find the cardiac output to increase by 10%, that means in this case 2.6. In this case from 2.6 say 0.26. If it increases, become 2.6, it becomes 2.9. Okay, 10% increase हो गया ना ये. अगर मेरा 2.6 से 2.9 हो गया, तो 10% increase हो गया. Then this suggests that this patient is fluid responsive. Clear? After this, what you do? You will get this patient back to the same position you were at, and things should reverse back. Things should, because it's a reversible fluid challenge, so things should reverse back. समझ में आ रहा है? Things should reverse back. The cardiac output should again go back to what it was. If you have done the test properly, the cardiac output will go back to what it was. 2.4. Clear? 2.6. Clear on this? So this is the principle of passive leg raise. Clear on this? Clear? Any questions on PLR, on how to do PLR? Any questions?
Increase by 10% and should get back by 10%.
It should get back. It will, no, because it's reversible. The principle of PLR is it's a reversible fluid challenge. If it's a reversible fluid challenge, it should get back. Clear? It should get back. Clear on this? So PLR. But though I am not really concentrating on the reversing of it, but it will ideally get back. Clear?
So this can be done by pulse pressure variation method also.
You can't know. What do you need to monitor?
Cardiac output and stroke.
Pulse pressure variation is the variation. It's not cardiac output. It's not stroke volume. So you can't use PPV at this moment like this. I'll explain to you how we can use it though. Clear on this till now? I'll explain to you how we can use it. Okay? Clear?
So Pico is not available.
Can't Pico. There's no other way to do it. You have to have the way, or you should learn echo. That's why we say echo is the background of ICU. That's why I say echo करना बहुत ज़्यादा ज़रूरी है. If you don't have Pico, the only method left is echo in a spontaneously breathing individual. In a spontaneous. It is very simple. You take the aortic valve, put a Doppler, just press his head, just hit PW. Immediately you get it. It's very simple. It's the simplest thing. You just have to find the aorta, aortic valve like a Mercedes-Benz sign करके आएगा. After you do that, you just put a
long axis view.
Just keep turning it. You get 5 chamber.
Okay.
When you get 5 chamber, you get aorta in the middle. You get the artery, all the 4 chambers you get. Once you get the aorta in the middle, put the pulse wave Doppler into that and just hit the button. Okay, when you hit pulse wave Doppler, zoom, that will come. Then you move the patient and do this at that time. At the same window, same time, you do the same thing. You get the answer. PLR. Clear? Clear on PLR? Any queries on PLR yet? Huh? Okay, so this is about spontaneous breathing individuals. So sometimes you may also hear something called as IVC collapsibility and distensibility index. Now what is that? Any idea what is that?
Collapsing with respiration like more than 50%.
So how you do this is, how do you do the go ahead. Collapsibility index is called CIVC. Is maximum diameter IVC max minus IVC minimum divided by minimum, max. ठीक है, IVC max, ठीक है, IVC max minus IVC minimum divided by IVC max. This is your IVC collapsibility index. So how do you do the IVC? How do you actually monitor the IVC in spontaneous breathing individuals? So how do you do it? You put the probe, let the patient be supine, slide propped up is allowed. You put the probe in the center, in the longitudinal axis, you will see the IVC entering into the right atrium. You have to find that junctions 2 centimeter away from that, not near the confluence of the hepatic artery. You are supposed to measure. Okay, you can measure in the B mode, you can measure in the M mode. Clear? You can measure in the B mode, that means the normal mode that you're using, and you can put in the M mode and measure it as a line. You can do whatever you want, but it should not be at the confluence. It has to be away from the hepatic artery. It has to be 2 centimeters away from the entry into the right atrium. It has got its own set of problems, the parallax and all those things that come in. Okay, when you do this, and what we say in that in IVC collapsibility index, if by any chance it is more than 40%, if it is more than 50%, okay, maybe this patient is fluid responsive. If it is less than 20%, it is highly unlikely that the patient is fluid responsive. Highly unlikely. But it is not as good a test as compared to PLR. Okay? It is highly unlikely that the patient may not be fluid responsive. But the problem is 90% of our patients fall in the grey zone. You understand? More than 50% we are thinking, this is IVC collapsibility index is good. Correct? Correct. And that's why you have to measure it. You cannot just do it. You cannot just look at it. You have to measure it. Okay? Less than 20% we say maybe they are not fluid responsive. Clear? Our problem is not less than 20 and less than 50. 90% of our patients in intensive care is in the grey zone between 20 and 50 where nothing can be told about them. 90% of our patients. That's why if you start monitoring, you realize how many of our patients actually fall into the collapsibility index. Correct? When you actually put the mean down here, this becomes distensibility index. When you do the same thing with the mean down here, it becomes distensibility index. Distensibility index is usually done for ventilated patients. The same thing when it does for ventilated patients is called as distensibility index. The difference being the denominator becomes the mean. Clear on this? Clear on this? So when you have distensibility index, the numbers are not 15%. The numbers are 18 to 20%. So if it is more than 18 to 20%, we call those patients to be query fluid responsive in distensibility index. And if it is 12% and lesser, it is called as fluid, suggested that the patient is not fluid responsive. Again, 90% of your patients will lie in the grey zone. 90% of patients will lie in the grey zone if you monitor it properly. Clear? So the way you are doing it now is really not appropriate. You just put the probe and you say IVC is collapsing. It doesn't work like that. It really doesn't work like that. It is wrong to do something like that. Very, very wrong to do that. Okay, if Dr. Ambedkar is doing it or somebody else, choreographers is doing it, they are doing it because they are so trained in it. कि उनको monitor करने का, they don't really need to look at the measurements. And otherwise also they look at the measurements and they write. If you look at it, they actually do the measurements. They have the numbers besides on their echo, and that's when they put it down there. You understand? So you just putting the echo and saying it's IVC is collapsible doesn't make any sense only. Okay? Are you getting the point? It's absolutely nonsense when you do something like that. That's why I don't even listen to you all when you're talking about IVC. I don't even listen to you. Why don't listen? Because you don't know the basic game. Background in the and that is the reason that you should henceforth do this, because 90% of your patients will fall in the grey zone where you will not know what is to be done. You're getting the point? You will not know what is to be done in 90% of your patients. That fall. That's why you should do the index like the way it is supposed to be done. Do the collapsibility index or the distensibility index like the way it is supposed to be done. Clear? So, what you might have understood by now, near about that IVC is almost out. You can't use the IVC if you ask me. Almost out. Because it not only depends on you insulating, it also depends on you insulating well. If you put the image in a different way, if you put it the way it is, it's very operator dependent. So if you put the image, you cut the IVC like this slanted, everything will change. If you cut the IVC slanted, if your IVC is like this, and you cut it like this, rather than cutting it like this, it is again a problem. You cut it slightly near the confluence of the hepatic artery, where there is a slight increase in the size. Again, things are different. You understand? You insulate the patient in such a way that rather than becoming a cylinder, it becomes a cube like this. If you insulate it in such a way that rather than being like this, it becomes like this. Again, the length is changing. Are you getting the point? There are too many parameters that interferes with the measurements. And that's why you will realize that IVC is not a great tool at all, though we can talk about it because that is the only thing that people have usually in the ICU. Are you getting the point? So an IVC is not a great tool if you ask me for fluid responsiveness. So we are left with a condition that if the patient has any of these spontaneously or passive or active, the one test that I can use combined for all of these things is PLR with the presence of LVOT-VTI or stroke volume and cardiac oximetry. Here, this is one of the tests that can be used for every and any patient excepting those three patients that I said: raised ICP, increased intra-abdominal hypertension, and spine surgeries. Clear? Now, what happens is you have a patient that is on ventilator. Okay. Now we finish the spontaneous, correct? Spontaneous is almost done. Okay. Now you have patient on the ventilator. This is our concerned patient where you have hypotension, they are not doing okay, you have done all your resuscitation, lactates are not coming down, you feel maybe capillary refill is not okay, I need to change something here. So what do I do in these patients? So first, what we have understood is I can use my passive leg raise. But that's not what we have always, no? Like you cannot keep putting PICO to all your patients. Some patients may be unaffordable, we don't get government stock, we are paying out of pocket. Some patients will not afford the PICO. Okay, if they don't afford the PICO, we are left with the condition that we need to use what we have. And what do we have in these cases? All of these patients usually have an arterial line. When they have an arterial line, just on the monitor you can get pulse pressure variation. You can get that. On the monitor you can get pulse pressure variation. Correct? All of the monitor you can get pulse pressure variation. Now what did I tell you at that time? Pulse pressure variation will work only when patient's atrial volume is high, patient does not have arrhythmia, patient is giving compliance of the lung is okay, and patient is not breathing excessively. That is when PPV will work. But we are not going to use PPV as a number again, because we are not going to use these things. We are not going to use PPV as a number. We are going to make PPV even more dynamic. Abhi the PPV is dynamic fluid responsiveness indicator, but it needs so many things to come in place to interpret it. Correct? It needs so many things to do. So we will not use PPV as that number. We will use it with the combination of a dynamic test. So what do? So if I have a patient like this, I will do the PLR on that patient. What should happen when I do PLR? Sneha, what will happen? So PLR, you now understood what is PLR. You have understood what is PLR. We're going to take the leg up, we're going to look at the PPV. Now we don't have cardiac output, we have PPV. What should happen? You've understood what PPV is? What should happen to PPV? Should it increase, should it decrease, should it remain the same? When you do PLR to indicate fluid responsiveness. What should ideally occur?
Increase.
Sorry?
It will increase.
No.
It should decrease.
Why? Correct. Why?
Because the fluid, we are given the fluid and patient is responding.
Correct. So it's so simple. When you have PPV, pulse pressure variation, what do we say? More the variation, chances of fluid responsiveness is higher.
Higher.
We just said that, right? We said when all these conditions are there, if it is more than 13%, means the variation is high. When the variation is high, there is a chance that the patient will be fluid responsive. Correct? This is what we said. So if the variations become low, okay, that means the patient is no longer responsive. He has got the fluid, he responded. You understand? Because when you give the fluid, the patient has responded. The variation has come down. Why is the variation there? The variation is there because venous return was reducing. Since venous return was reducing, stroke volume was not improving. You understand? And since stroke volume was not improving, the patient's cardiac output was low. That's why the next couple of weeks the cardiac output became low. Okay. Now what has happened? The variation has reduced. Since the variation has reduced, mostly this patient is fluid responsive. So I will do the same PLR with the same PPV, with the difference being I will see for drop by around 2 points. 2 points, not percentage. 2 points. If my PP was 8, if it drops to 6, I am doing good. You get the point? I am doing fine. No problem. So I can do my PLR just with PPV. Are you getting the point? I do my PLR, look at the change, and if it's dropping by 2 points, it suggests that this patient is fluid responsive because the PPV, that is the pulse pressure variability, is actually reducing. Getting the point? Have you understood this point? Is it clear? Understand this? So this is one way I can do this. This is one way I can do it. The other way I can do it on a ventilator is by doing something called as an end expiratory occlusion test. End expiratory occlusion test. Now that you understand what is PPV, now that you understand how PPV variability is occurring, can you describe what is going to happen in end expiratory occlusion? Avinash, can you describe? What am I doing at end of expiration? I am occluding now. End expiratory occlusion. क्या होगा? What is going to happen?
Alveoli will be inflated, so same thing will be happening what was happening with the expansion of the lungs and the effect of the heart.
Correct. So in the lungs, exactly. So when you are giving end expiratory occlusion, you are occluding at the end of expiration. When you are occluding at the end of expiration, the entire dynamics will again change. So it's like a fluid challenge again. So what will you see? Increases stroke volume. You get the point? So when I'm end expiratory, when I'm occluding, I'm pressing end expiratory occlusion on the ventilator, end expiratory hold. When I'm pressing end expiratory hold on the ventilator, I have stopped the respiration. Since I stopped the respiration, venous return is changing, everything is changing. It is like a fluid challenge. Similarly, if the stroke volume goes up 10%, actually 5% in expiratory, only 5% stroke volume is enough. Even if it increases by 5% of cardiac output of stroke volume, it means it is fluid responsive. How do you do this test? You do this test by, first of all, it is very obvious that if the patient is breathing excessively, you can't do it. He's not going to occlude, end expiration allow nahi karega. If he's breathing, and you occlude it, there's no point. He's not going to allow that occlusion. वो breathe करता रहेगा. We want to stop him from breathing at end of expiration. You understand? So if I press end expiratory occlusion in a patient who's not breathing heavily, what you're supposed to do as a prerequisite, you change the apnea alarms. If it is 10 seconds apnea alarm, problem ho jayega. Change the apnea alarms, press end expiratory occlusion. Then wait for 10 seconds. At between 10 and 15 seconds, till 10 to 20 seconds, okay, मतलब you 10 seconds के लिए hold 15 seconds तुम hold कर रहे हो. जब तुम hold करते करते you are looking at cardiac volume, you are looking at stroke volume. At the 10th second onwards, keep a close watch. From 10th second onwards. From the 10th second onwards, once you see the cardiac output is changing, and is changing by 5%, that is called positive for fluid responsiveness. Clear? Simple test. So my first test I would always talk about is PLR with PPV in our given scenario. The next test that I will talk about is end expiratory occlusion. Okay. Now, unfortunately, it has not been yet proven with pulse pressure variation. It has been proven only with cardiac output and stroke volume. Clear? So you can't look at PPV and say PPV change हो रहा है. It's till now not been proven that well. Okay. As of now, PLR and PPV proven. Systematic reviews that are coming in that says that this is the way it should be done. End expiratory occlusion test still with cardiac output monitoring. Okay. The third test you can use in these cases is called as TVC or called as tidal volume challenge. Tidal volume challenge. And what is tidal volume challenge? In tidal volume, what are we doing? Our problem is your pulse pressure variation may not be shown because that the tidal volume is not causing that pressure to change. Understand? One of the reasons that pulse pressure variation may not be showing may be that the tidal volume कम है तुम्हारा, ठीक है? तुम्हारा tidal volume कम है, इसकी वजह से the pressure transmission into the lung and into the vessels is lesser. Simple. Transmission of pressure into the lungs, into the vessels is lesser, and since it is lesser, the pulse pressure variation नहीं हो रहा है. So what are we trying to do? I am trying to increase the transmission of pressure by increasing the tidal volume. I can't keep it at 10 ml per kilogram because if I keep it at that, it will cause it will lose the lung protective ventilation. That is what I'm going to do. I'm going to move my tidal volume from 6 ml per kilogram to 8 ml per kilogram. I'm going to move it from 6 ml per kilogram to 8 ml per kilogram. Look at the pulse pressure variation. Here I will look at pulse pressure variation. I can even look at cardiac output shock if I have, but pulse pressure variation is there. It is proven with pulse pressure variation. I do pulse pressure variation, and again, if the pulse pressure variation changes by 10% or by 2 points, 2 to 2.5 points, it indicates. So in this test also, what I will do? Increasing my tidal volume, looking for the next 30 seconds. 30 seconds to, we are not going to give it for a long time. 30 seconds में 2 या 3 breath जाएगा, ठीक है? वो 2-3 breath में we will see what is happening. Those 4-5 breaths that goes in, we will see what's happening in those breaths. In those breaths, if there is a change in the pulse pressure variation by 2.5 points, you can assume or it is suggested that the patient is fluid responsive. ठीक है? Clear? So I'm not going to go into more details. So I'm going to make it very simple. Patient comes in, I can do IVC collapsibility, I can do IVC distensibility for ventilated and non-ventilated patients, but I have to do it like the way I told you. I will first understand, I'll question myself whether I need to think of fluid responsiveness. And whenever I do anything in the ICU, I think of an end product. My end product should be what? Either normalization of lactate, or improvement of capillary refill, or altered mental state is getting better, or the blood pressure getting better. This is the reasons for which I am doing this. Right? I have to think like this. कि my ultimate goal क्या है मेरा? ठीक है? Ultimate goal क्या है मेरा? Clear? And then I will think where I am supposed to be. I will dichotomize into 2 parts. Spontaneous breathing, ventilated. If it is spontaneous breathing, PLR and LVOTI or cardiac output. If it is not spontaneously breathing, on ventilator, active or passive. If it's passive, good tidal volumes, I can use PPV, I can use tidal volume challenge, I can use end expiratory occlusion, I can use PLR PPV. Patient is not actively, patient still breathing actively, PLR with PPV. PLR with PPV. Clear? And if by any chance patient is not having too much of respiratory attempts, TVC, tidal volume challenge. ठीक है? Or end expiratory occlusion. If the patient does not have too much, if patient हर चीज में वो breathe कर रहा है 30-35 respiratory चल रहा है, you can't do all those things. Clear on this? Clear? So this is not the end of the story. No. What do we do? अगर वो fluid responsive निकला, what is the next step? What is the next step?
Maintenance.
What is the next step? No. This means to say I now need to give fluid, na? If the patient has come in and I found out that the patient, I was thinking whether the patient is fluid responsive. Now first thing I did was I asked the question whether this patient will benefit with the fluid by improving perfusion. This is my ultimate objective. Okay, I asked that question. The second question is, what is my incidence that the fluid will actually cause improvement in stroke volume or cardiac output, or basically called fluid responsive. And the third thing is whether I need to repeat this thing over here. And the last question is whether the perfusion has got better. So I have 4 things that I have to see. You getting the point? So how do I do this? So after doing this, I need to give my intervention. and my intervention is 250 ml of fluid given fast. That's my intervention. My intervention is 250 ml of fluid given fast. That is my intervention. Okay, this means to say, how in timelines, if I say at 0 point when the patient comes in, I will quickly figure out whether the patient needs a fluid bolus. For I'll understand whether the patient will benefit with this, may or may not. Is there a benefit? Is there a possibility that will benefit with the fluid? And then I will charge fluid responsiveness. मतलब 2 minutes में 2 या 4 minutes में fluid responsiveness. 5 minutes I can take to get my fluid responsiveness done. ठीक है? Then I give the fluid. Okay. After I give the fluid, I then again keep myself aside. In the next 2 minutes after my fluid responsive, after giving the fluid, in the next 2 minutes, I will go back and check fluid responsiveness. Because it's 250 ml. It's not 500, it's not 1000, it's 250 ml. Are you getting the point? Since what will happen? 0 point, I am understanding and asking the same question as to whether this patient may benefit with the fluid because of all those parameters that we discussed. At 0.5, I have decided a fluid responsive test. At 5 minutes, I have decided this is what I'm going to do here. At 6 minutes, I have figured out the problem, so I have given fluid here 250 ml. The fluid has gone in within say 10 minutes. And at 10 minutes, 11 minutes, I am again going to do my tests. Because patient who is now fluid responsive may not be fluid responsive 10 minutes later. The patient who is now responsive may not be fluid responsive 10 minutes later. Okay? If the patient is fluid responsive and the patient has not improved, I want to give my second fluid bolus here. You getting the point? And then I will wait for 5 minutes. So do this twice and then I'll wait for 5 minutes. At 5 minutes after the fluid challenge, I will now check my perfusion markers, which I thought.
Lactate.
If I want, I can do my lactate, I can do my capillary refill, my altered mental status, my urine output, and my blood pressure. So I will have my targets in my mind. My target रहेगा capillary refill कितना improve हुआ कि नहीं हुआ. So what will be your notes will be? Your notes will be patient has got these features. I have tested to figure out fluid responsiveness. The test of PPV versus TVC or PLR PPV has suggested that this patient may benefit with a fluid challenge. He may be fluid responsive. I gave 250 ml and I re-challenged the system to understand about whether the patient requires more. And at 5 minutes after this, I have found out that the lactate has improved, the capillary refill time has got better, whatever my parameters were at the end, to signify that I have done the job that was intended to be done when it comes to fluids. Are you getting the point? So the entire point is that you don't give a drop of fluid without testing. Testing, retesting and confirming what you wanted to do. You getting the point? You may first find it is very cumbersome. It is not cumbersome. It will actually make your confidence get better if my fluid has worked. Unfortunately, you all end up giving the fluid and then testing. Many times urine output is not improving. Many times lactate is not changing. Capillary refill not checked. How do you know that it's moving? Urine output can't be a judge. You understand? It can't be your only judge. There are other things. It's possible that you gave the fluid, capillary refill time got better. Urine output didn't improve, but you have done the job. Your capillary refill time has got better. Perfusion has improved. You're giving the fluid, alternative has got better. You're not going to you have done the job. Your job was to see whether this end parameters were getting better. And you know, now the trajectory is better. The patient's some parameters have improved. Now the trajectory is better. Patient is going to improve. Are you getting the point? That's why fluid responsive and fluid should not be taken lightly. It's not a simple question, give fluid or don't give fluid. It's complex. It's complex. Now you have to understand whether the patient is wanting the fluid, whether the patient is responsive to the fluid, and whether the patient, after giving that fluid, responds to that fluid by improving perfusion. So there are 3 aspects to that. You understand? And that's why you should never take fluid challenge or fluid lightly in ICU. You can take, I don't want to take it lightly anywhere in the world. But compared to the ICU, the ER and the wards don't cause so much of an issue. Are you getting the point? The wards and the patients are not so sick. Here the patients are very sick. Are you getting the point? So you can't give the fluid and now check after 1 hour. There's no point only. There is no point only. After 1 hour, things have changed, compensation has changed, body is compensating, stress volume is changing, so many things are changing. You understand? So the adequate time to do it is 5 minutes after your fluid challenge. Second fluid challenge. 5 minutes after your second fluid challenge. You're supposed to check. Second, if you cannot do the second fluid challenge, 5 minutes after that you have to check this. You're getting the point? If you check that, and your note should say that. If you are given that 250 hours, note should say that I checked it at this time, we put the timing, this has changed, patient has improved. If it has not, then I have to rethink. There is something really wrong with the physiology. I need to do a lot of other things. Maybe I need to change my antibiotic, maybe I look at the heart, I need to do a lot of other things. Maybe I have to start vasopressors, I have to increase the vasopressors, reduce what vasopressor. That's a different explanation only as to what is to be done and which vasopressor and what to do, whether I should do it, whether I should not do it. That's a different thing only. But fluid is the fluid topic ends here. Okay, how to do these things. Are you getting the point? Clear? You know what we discussed is by doing an auto challenge. We discussed by saying we take the fluid from the body and put it inside and then we reverse that. And that's the beauty of ELR and that's the beauty of all these dynamic fluid indices. PPV and SPV and all this that we're doing. Tidal volume channels. That's the beauty of it because you're not giving an extra drop. It's just going in. But sometimes it does happen that you can't do anything on these and you want to do it, want to do something different. So you may want to attempt something called as a micro or a mini fluid challenge. Now what is a micro or a mini fluid challenge? It's giving 50 to 100 ml fast and seeing what's happening. Of course you are given that fluid. You cannot reverse that out. You understand? You can't reverse that out. So 50 or 100 ml given as full as a bolus fast through a syringe. 50 or 100 ml given as a bolus. And you do the same thing that you are doing. If the PPV reduces, if there's all these things happens, if the VTI increases, cardiac output increases, you can actually call this as fluid response. But there, what has happened? You have given that microfluid challenge, that mini fluid challenge, you have given it. Are you getting the point? So, I would probably not do that per se. I would still look at all of these things that I explained to you. Clear?
Tidal volume challenge like indication content.